So, good morning, and I hadn't realised before how inaccessible my bio is. It seems to have loads of words that are very difficult to read. It reminds me a bit of, in the UK, we had somebody called Derek Walden, who was a man with a lisp. He couldn't say R's very well. Every time he tried to say the word R, he came up with a W instead. And I think that the people who wrote for him must have had, I think they must have had a bad day at the office, or he'd had a bad day at the office, and they decided to show him up. When he started his, straight after the American presidency, the TV program started. It was full up, just head and face of him, and they had written for him to say, Ronald Reagan's Republican Party romped to victory at the start of, in the last election, which of course he had some difficulty saying, and it did actually ruin the moment. So anyway, good morning, and it's good to get you laughing because everybody thinks more and learns more when they laugh. First of all, I need to thank Sandy and Sharon for getting you all in the room, because I think it looks like it's going to be a fabulous day, and also as I say, the white team with these lovely, those T-shirts are fabulous, and I think the image that's on them is really quite compelling. So I love these T-shirts. I also like to thank Lynn for her excellent start, because it makes my job much easier now that she's talked about health equity, and also the fact that Toy Lynn has managed to bring the human experience into the room, which I think is a really good architecture on which to start putting some of the information that I'm going to give you, because this talk is going to be information rich. Now, usually I give my talk and then I leave. That might be because my talks are boring and I don't want to stay around and find out what you all think about them. But I'm actually going to be here all day. And so we've got a situation where if there's anything I talk about that's, I don't explain myself properly so people don't understand, I'm going to be here all day so you can always ask questions. I'm going to be talking a little bit about mental health, a little bit about immigration and diversity, and something about health equity. I need to start with a health warning. I talk quickly, and there are lots of slides. The reason why there are lots of slides is because I will leave them on this computer. They'll also be on the web, and so you can refer to them at any time. And so all the information is going to be on slides. You can pick it up at any time. But what that means is for the people who like to furiously write, you don't have to. You can relax. You can just listen to the presentation, and you can be reasonably fresh, because I know from now till 12:30, you're going to get a very rich period of time, which can sometimes leave people slightly exhausted. This is a good time to be in psychiatry and in mental health in general. I needed to start because I know it's going to be a mixed audience, just talking a little bit about mental health. And people sometimes talk about mental health and mental illness in the same breath, but they're slightly different things. Mental health is this idea of a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. And this is pulled from some of the World Health Organization documents that Lynn talked about. If that's the case, then mental health is a foundation for well-being and effective functioning in communities and economic prosperity. And there's this oft sort of used term, which is there's no health without mental health. But I think you can go further. If we're talking about economic prosperity and people being able to live productively in their lives, there is actually no wealth without mental health. Mental illness is slightly different. Mental illness is significant patterns or emotions that are associated with distress. So that it's different. It's an illness. It's patterns of behavior, it's patterns of symptoms that we diagnose as illnesses. But it's very important. Four of the top leading causes of disability are mental illnesses. And in Canada, 30% of disability claims, and actually 70% of the money, is due to mental illness. So mental illness is really important from a disability perspective. And it also means that in Canada, we're spending $51 billion every year on mental illness. 51 billion. We sometimes talk about mental illness and mental health, but we don't really think about what's really going on. This is a really schematic just about what happens. While you were talking here and you were sort of in the back of the room networking and you were part of community, you were sitting there in balance and you were quite happy. I stood up and gave you some alarming figures and you started getting distressed, okay? Then I started trying to be funny, and hopefully you moved back to balance, unless I wasn't funny enough when you just you stayed in distress, okay? You move from distress, if things keep on going wrong, down to regular symptoms causing problems with functioning, at which time a lot of people try and seek help. If it doesn't work when you seek help from family and friends and other people, you then go to your GP, and if that doesn't work, you see a specialist. That's the normal pathway that most people take. Obviously, if things are extremely acute, you can move straight from balance to an emergency department. But actually, most people go through this pathway. You move down the pathways if your life events, your stress, and your internal vulnerability are great, and you move up if you've got increased levels of resilience, your coping structure, which can be a community structure, and the safety net, which is usually services. If you've got good mental health, that pushes you up. If you've got poorer mental health, that pushes you down. And when you're listening to Toy Lin, the thing you might have thought about is that there are all these life events. Then there were stresses once they moved into Canada that were moving down. And then the lack of some of the sort of normal coping mechanisms and safety nets were stopping pushing her up. What we do at every level is we try to get to the level above. When we come down, we try and push ourselves up. We get more of these coping structures, safety nets, into our pot to try and move us up. That's what we're trying to do. And to a certain extent, that's what services are also trying to do. Move people up towards balance. The renewed optimism there's been in mental health recently has been because we've got evidence-based health promotion strategies. We've got really good illness prevention strategies, and we've got very good treatments. Most people from an episode of mental health problems, mental illness, get better. Now, people may get ill again, but most people get better. So we're actually fairly effective at doing things if we have the money to do it. The health promotion work, and I was glad to see that that Lynn talked about the Ottawa Charter. Health promotion started in Canada. The first declaration was the Ottawa Declaration. Then there's been the Jakarta Declaration, and now there's a Bangkok Charter. And it's really, really challenging stuff because it's not about just treating people as when we're talking about sort of services. It's about a whole government approach to trying to produce environments that keep people well. That's what health promotion's about. It's big stuff. It's cross-governmental stuff. It's developing supportive environments. It's increasing community efficacy and human capital. And it's reorientation away from illness services to real health services. Our prevention work, we do some very good work, and there's some wonderful things. Did you know that if you are at high risk of postpartum depression, and there are a number of people at high risk of postpartum depression, peer support can decrease you developing a depression by about 50%. Really cheap. Peer support, linking somebody who has had postpartum depression up to somebody who's at high risk of postpartum depression, can decrease the risk by 50%. 50% for all groups. So we know how to do that. We know how to treat people to prevent chronicity of illness if somebody gets ill. We know if we get help early, we can stop people having long-term illness. And we know that if we link mental health services to social services, we can decrease the secondary impacts of mental health problems. We know that we've got psychological treatments like CBT that work brilliantly. There are social treatments, and then the drugs are becoming better and better and causing fewer and fewer side effects. We know that we've got, as Lynn talked about, evidence-based. If you look through achieving about closing the gap in a generation at WHO, and I'm jealous because you've got a better picture. Better resolution, but it's not competition, really. No. But we know that that you can that if you look through that, and if you look through the back documents for it, there's loads of really neat, cost-effective, evidence-based promotion and prevention strategies that have been pulled from all over the world. We know what to do, and with the Mental Health Commission, we will have our evidence-based treatment strategies all organised as well. So all in all, it's a great time to be in mental health, and it's a great time to be in mental illness as a service provider. But there are problems. And the problems lie in the way we set things up. This is a very simple diagram that's some people think that what it seems is purple is the colour of CAMH. So if you're in on Ontario and you show this sort of slide, they think this slide means that CAMH is taking over the world. That's not what the slide is supposed to show. It was just it just happened that way. So the big purple dots are the cities with over 1 million people who are foreign born. The green dots are places with 500,000 to 1 million, and the red dots are between 100,000 and 500,000. All over the world, everywhere in all the high-income countries, there are cities with large numbers of immigrants, foreign born. There is nowhere now in the world, in the high-income countries, where mental health and psychiatry is not cross-cultural mental health and psychiatry. You can't get away from it wherever you go. And you really can't get away from it in Canada because immigration is the main driver of population growth. What people don't realise is that despite the fact that it can cost you between $30,000 and $40,000 to get here, Canada is in a global market for immigrants. We're looking for high-functioning, clever immigrants in order to build the country and in order to, not that it's all about me, but pay my pension. Because in the future, our prosperity is linked to immigration. Canadians are not having as many babies as they should. You know that, don't you? You've seen this. You've seen the statistics. Canadians are not having as many babies as they could, and left to our own devices in Canada, we would have population shrinkage and we would have economic shrinkage. The way we're building is by growing, and we're growing on immigration. So immigration's important, and we're in a global fight to get the best immigrants here. And at the moment, if you just look between 2001 and 2006, immigrants are going various places. This is none of it, 100% increase in immigration in a 5-year period. And we're in Nova Scotia, where it's about 10%. That figure, I think, is incorrect. It takes a 2001 to 2006 figure and compares it to decades before, though it's a 5-year period. But PEI, 55%. New Brunswick, 41%. All over Canada, we've got an increase in immigration, which on average perhaps 30%. But that's where we're building the economies. And the economies that are building quickest are the economies that are taking most immigrants. Now, this idea of immigration, sometimes we think of immigration as a one-size-fits-all sort of stereotype. But we've got to realize that when we're talking about immigration, we're talking about very diverse groups of people coming from loads of different places, diversities around who is coming where and at what rate people are coming, and the significantly changing demographics that are different in different provinces. We also need to remember, and this has come out yellow for some reason, and hopefully this will be talked about later on, is there is actually some intersection. So we tend to think of immigrants and we tend to think that immigration or ethnicity or culture is the most important thing. And then we forget the intersectional issues of gender. We forget the LGBT issues, which are sometimes brought to the fore in different immigrant groups. We forget culture and religion, and we forget the diversity within diversity that can cause different problems. Just a quick snapshot. If you look at 1961 before, 90%, this big blue line, of people who are coming from to Canada were from Europe. If you fast forward to 2001, 19% of people who are coming to Canada are coming from Europe, with most people coming from East Asia and the Middle East. If you look at Nova Scotia, it's slightly different. We've got about, looks like 7,500 people come from USA. Most people still coming from Europe. The Asian diaspora is increasing. South Asian diaspora is much smaller. Southeast Asia diaspora is smaller. And the group from Africa is relatively small compared to the rest of Canada. But the trajectory is definitely up. The projection between 2001 and 2011 is that there'll be about 14,000 immigrants coming to Nova Scotia, which is an increase from about 6,000 to 7,000 on average that there'd been over the past decades. Immigration tells you something about who's here, but it doesn't tell you about the existing diverse population who are not immigrants. And there are a number of diverse populations, as you know, in Nova Scotia that would never come on the chart as immigrants because they've been here 300, 400, 500 years. If you look at, and the phrase visible minority is a phrase that's used by Statistics Canada to talk about minority groups other than Aboriginal groups. On the 2006 census, there are about 37,000 people who would be considered from a visible minority in Nova Scotia. About 20, if you compared that to the Aboriginal population, which is about 24,000 in Nova Scotia, and if you look at the immigrant population, which is 45,000 in Nova Scotia, 19,000 black, about 4,500 Arab, and 4,300 Chinese, and then you can see where the rest come from. And we'll come to this later, but the important thing here is that when you look at people's mother tongue, you've got 34,625 people who say that their mother tongue is not English or French. And that's quite important because when you think of barriers to care and you think of what type of services people are going to offer. Now, just moving back to what Lynn said, and just talking about the definition of health equity. Health equity is not about inequalities necessarily per se. It's about avoidable inequalities, things that we can do something about. So it's actually sort of outcome and action focused. It's about things we can do something about. And they fall into two particular groups. One is the social determinants of health that we might be able to do something about. And the other is our service response, which are things that we can do something about. And the reason why I've talked a bit about health promotion and illness prevention and what a great time it is to be a psychiatrist, and then I've talked a little bit about immigration, is because what we've actually got at the moment is wonderful, great, superb, evidence-based prevention, promotion, and treatment strategies, and we haven't tested them on diverse populations. So we've got a potential health equity problem. We haven't thought about the way we set up our services to meet the needs of diverse populations, immigrant populations, existing ethnocultural populations, refugee populations. And we're starting to realize, when we start doing the research, that one size does not fit all. In fact, when they were setting up the Kirby Commission, or the Mental Health Commission of Canada, they did a comparison of a number of countries, including the USA, the UK, New Zealand, and Australia. And one of the big things that came out of those documents, and I must admit, these documents are completely fabulous. They're a fabulous read if you're really interested in mental illness. If you're not, they're a fabulous read to put you to sleep at night. They are really, really thick, detailed, wonderful, superb documents, but very, very weighty. And they said that actually this is something very similar to the diagram that I showed before, where cross-cultural psychiatry is psychiatry, is that in high-income countries, developing services for a multicultural population is a common challenge. And if you don't do it right, if we don't do it right, people get poorer access to care. The research shows that people are more likely to use crisis and emergency services. The research shows that people are more likely to end up in prison or the prison justice system, that there's increased levels of hospitalization, that outcomes are poorer, that the community gets burdened by the amount of mental illness and mental health problems that there are, and that suicide rates increase. One of the other things that happens, and this was shown by a group called the Sainsbury's Centre for Mental Health in the UK. Now, Sainsbury's is a supermarket very similar to Loblaws, but Sainsbury's use some of their profits to do mental health research. And what they showed is, if you look at a typical person of African and Caribbean origin in the UK, and you compare the amount of money you're spending on mental health for them once they get in the system, compared to a white British person, that you're spending 38% more on the person who is African and Caribbean. And we were spending more in the UK because we weren't setting up our services properly, so people were ending up in hospital. And hospitalization is the most expensive way of offering a service compared to community services, compared to keeping people well. So it's not only a challenge, if you don't do it right, it costs you. It costs you long term. And it costs you in a number of different ways. So, has anybody ever seen a Wordle before? Sorry? Yep? You've seen Wordles. Okay. So all this is all the research that has happened in Canada on mental health and mental illness in immigrant, refugee, ethnocultural, and racialized groups. We took the titles, we took the abstracts, and we put them into a Word file. We then put them into this computer program, and this computer program counts the number of times a particular word is used. If it's used a lot of times, you get a big representation. If it's not hardly used, it ends up microscopic. And these are just the top 100 words, okay? And because I've been talking for half an hour, it's time for some participation. What do you think's missing? You can shout.
Wellness.
Sorry?
Wellness.
Wellness, not on the map in our research, in Canadian research at the moment. Should be. Sorry?
Racism.
Racism.
Yeah,
No, you won't see it in the research either. It's not there. Inclusion, it's not there. Equity, not there. Homophobia, not there. Intersexual issues of, being gay, lesbian, bisexual, and immigrant, refugee, ethnocultural groups, not there, though it is a big problem. Prevention, not there. Sorry? No, not there. People, they tend to look at particular populations rather than thinking of a diverse population in general. Sorry?
I was just going to say I see barriers, but I don't see abilities.
No abilities. No, it's mainly dominated by medicine, and medics are problem-focused because we do stuff, and so we look for problems and try and fix them. And that's part of the way that things are hopefully changing, that we try and prevent problems rather than look for problems.
Non-status?
Sorry?
Non-status?
Non-status people or people on temporary work permits, no, not there.
Quality of life?
Quality of life? Oh, jeez, this is socialist or something. I must have come to Nova Scotia. Quality of life? This is, no, it's not there. This is medical research. No, quality of life should be there. Homelessness, not there. And it's interesting that in the past, people have thought that immigrant, refugee, ethnocultural groups less likely to be homeless. And in a lot of studies, that's what it shows. But much, much, much more likely to be poorly housed and on the brink of homelessness. But the social safety net sort of comes in to save people. Yeah? Access, not there. Sorry? Community. Community is there. It's small, but it's there. Yeah? People have looked at individuals to start off with. Now people are starting to think of community. Spirituality, surprisingly, not really there. Yeah. Last one? Stigma, not there, but a very important issue in every culture. In fact, there are three big bits of research. The first big bit of research is about rates of mental illness. The second big piece of research is about social determinants. And the third big piece of research is about facilitators and barriers to care. And you probably have heard about this idea of the healthy immigrant effect. And the healthy immigrant effect essentially states that when people are coming to Canada, physical and mental health problems in newcomers are fairly low, lower than the Canadian average, but then things change over time. However, remember, one size does not fit all, and particular populations, some refugee populations, have very high rates of particular mental health problems. This is a graphic display of what happens to people when they come to Canada. This line is people who arrived in Canada between 1994 and between 1990 and 1994. This line is people who are Caribbean born, and this line is people who arrived before 1970. And we're looking at the number of people who are looking at, or the percentage of people who are reporting fair or poor health. So basically, things aren't going well on a national survey. So these guys who arrived in 1994, between 1990 and 1994, are doing pretty well, better than the national average. And then as the time goes on, their health just gets worse and worse and worse. Okay? These guys arrived before 1970, and their health is worse than the Canadian average, and then the pattern of their graph mirrors changes in health status of the Canadian population, but their health is worse. So when we're thinking about health equity, there are two possible targets: how we bring this group down to the Canadian average, then how we stop this group coming up to the Canadian average. Okay? So we can learn something. We've got this, we spent all of this money getting healthy immigrants into Canada in order to build an economy, in order to build a wonderful community. And it looks like we've got about 5 years before things turn around. So for newcomers, that's the target. You've got 5 years in order to get people, to keep people well. For people who've been here for a longer period of time, the question is what you can do to bring them down to the national average. That's for depression, anxiety, and actually physical health, that last graph. This is for schizophrenia. If you are an immigrant, you're about twice the risk of developing schizophrenia. However, if you're an immigrant who's black coming to a country that's white, mainly white, you're about 4 or 5 times the risk of developing schizophrenia. That's the risk that was produced from the best study that there's ever been, which took every piece of data from every good study that there'd ever been and did a meta-analysis. And this was published in the American Journal of Psychiatry, which is not known to be a sort of left-wing pinko, publication. And so it's a serious publication. So this is, these are the facts. I tried to find some facts about Nova Scotia, and it was difficult because there wasn't a lot of research. But I was interested to find this paper, which again was from the Canadian Medical Association Journal. And if you've ever tried to get anything about common mental disorders or psychiatry into the Canadian Medical Association Journal, you know they've got a very high bar. It's a very good publication. And they looked at the rate of psychiatric disorders in Preston and basically found that there was a 13% increase in African Canadians. And not only was there an increase but in the incidence of the illness, but people were iller. And it wasn't explained by the socioeconomic characteristics at all, recent immigration or language. So something is going on in the African Nova Scotians, but there's not a lot of research that digs further down to work out exactly what. Usually, when people are looking at the causes of the problems, we talk about the social factors or social determinants. And social determinants tell us a reasonable amount. Social determinants that cause problems for everybody, like poverty that we started with, or housing that we started with, or that increase your stress levels, are the same for everybody. The problem with some groups, marginalized groups, immigrants, ethnocultural groups, racialized groups, LGBT groups, is you are more likely to experience the social determinants. So they work the same for everybody, but some groups are more likely to experience those social determinants. And then on top of that, there's less availability of the social forces that keep you well, the social safety net. Remember the structure that we talked about, the pathway that we talked about. One part of the pathway is pushing you down, and the part of the pathway that pushes you up is shrinking. But then there are also some novel social factors, such as racism, such as problems due to migration, and such as language difficulties, which increase the rates of mental health problems in certain groups. These are just a couple of examples. This is just shows the ratio of earnings of newcomers to the rest of to other Canadians. And there are 4 lines, and they just are whether you've got a university degree or whether you haven't, and whether you're male or female. And the important factor is, say for instance, take this line. In 1980, if you're a newcomer and you're a female without a university degree, your earnings would be about 85% that of Canadians who are similarly qualified to you. If we go to 2005, it's about 55%. Okay? So there's a huge change over time. Now that change has come for a number of reasons. Lynn talked about inequality and income inequality. And what's been happening over time in Canada is the rich have been getting richer and the poor have been staying very much the same. And so the gap between rich and poor has been increased. But what's happened for immigrants is that they're more likely to be in the poor group, and therefore their ratio of earnings has decreased over time. Now, income inequality is a social cancer. It breaks up communities, it breaks up families, it breaks up societies, and it breaks your economy pretty effectively. But it also breaks people. So you increase the amount of mental health problems, physical health problems that you can get. And one of the books that I commend you to that I think is on the reading list is The Spirit Level by Richard Wilkinson, which is all about what happens in unequal societies. Immigrants have problems. This is just Canadian-born versus immigrants, more likely to be unemployed, more likely to be on low income, actually more likely to be in need of housing, though less likely to be homeless. And it makes a difference. Forget about the different colours. All you're looking at here is immigrants who are earning the least compared to immigrants who are earning the most. If you're earning the least and you're an immigrant, 35% of people are reporting emotional problems, compared to about 20%, which would be the national average if you are earning the highest amount. So actually, within immigrant groups, there is a stratification of illness, mental illness, physical illness, based on the amount of money you're getting. So if you're starting off with the fact that immigrants groups are earning less, within the group that are earning less, there are people who are doing even worse. But all immigrants are not the same. You know, I showed you that line earlier where people were converting from being healthy to being not healthy in a 5-year period, okay? Now, this doesn't actually happen to all immigrants. This is a Canadian population, and that's the risk of a transition from good, very good, or excellent health to fair or poor health. And this is a Canadian average, Canadian-born population, and that's one. If you're a recent European immigrant, or if you're a long-term European immigrant, actually, you're not much more likely to convert from good health to poor health. But if you're a non-European immigrant, whether it's a short, recent non-term European immigrant or a long-term non-European immigrant, you are much more likely to convert from being in good health to being in poor health. So all immigrants are not the same. And these are statistically significant, and again, this is a published study that's in the public domain, and you can find it on the Health Canada website. There are also poorly researched factors such as racism. This is a complicated slide, but it's here just to show one thing, which is this dot here. What this dot shows is that if you are a refugee and you move to a country that has highly restricted practices so you can't work, you're 100% more likely to develop a mental health problem. Okay? Compared to places where you're moderately restricted or places where you're not restricted at all. Now, there are some things you can't do anything about. You can't necessarily do something about war in another country. You can't necessarily do something about people breaking in and trying to rob people in another country. That's not necessarily something that would be under the jurisdiction of the federal government. But you can do something about allowing people to work when they come to Canada. And if you did that, you'd decrease the levels of mental health problems in that community. You can probably also do something about this. I always put this data up from England and Wales because when I tried to do the Canadian data, everybody gave reasons why it wasn't reasonable. What this shows is the amount of racially aggravated crime between 1999 and 2004 in the UK. And this is assault and wounding, this is property crime, and this is racial harassment, which has been reported to the police, and the police have decided is a racially aggravated crime rather than is a not racially aggregated. So it's actually been through the filter of the police. So it's probably an undercount by about 10 times. That's what the studies in the UK show, that if you take people who go in and report the crime compared to what the police write down, the police write down about 1 in 10. They actually agree that about 1 in 10 are racially aggravated. Most crime, they don't. And you can see that it's been increasing over time. Why do you think it's increasing? Sorry? More immigrants? In the UK, immigration's stable.
More people reporting.
More people reporting? Could be. No? Sorry? I'm sorry? Can't. The economy. It could have been the economy. It was actually 9/11. So this is a 9/11 effect, and you can see what happens when these things happen. It was going up, coming down, going up, coming down. We had 9/11, bang. And it's carried on going up. And so this is, again, one of these things about there's different groups within immigrant groups that sometimes get targeted. And when you started looking, this was a huge increase in the amount of racism against South Asian populations who people thought might be Muslim. This is a very, very, very bad slide, okay? And consequently, every one of you I need you to memorize them. But you will remember this. This is hate crimes in Canada in 2006 per 100,000 population. And the Canadian average is 3.1, and Halifax is 2.3. Okay? So Halifax is actually below the rate with regards to hate crimes, though we don't know whether okay. They're just conferring about whether I've gone on too long. But I will respect the people who are coming after me, and I will keep to time. But there are different places like Kingston, like Ottawa, like Calgary, where there are much higher rates of hate crime. And the interesting thing when you see these sorts of disparities is what's going on. What can we learn? Yeah. What can the others learn from here? What can we learn from other people? What exactly is going on? Is it a reporting issue? Is it the fact that there are lower levels of crime? What exactly is going on? And so I think these sorts of statistics are interesting. There's also, not only with regards to the social determinants of health that are causing increased rates in one group or another that we could target as for prevention and promotion, there's also some very straightforward research about getting care. And this is just a study that was in the Canadian Journal of Psychiatry, looking at whether people get care. Whether people get care. And actually, you're less likely, much less likely to get psychological care if you are from an immigrant population, about 3 times less likely to get psychological care, and actually mental health service use 5 times less likely to actually get mental health service use. And that's not just because people are poorer or that they've got offering different symptoms. They just aren't going into care. And it's not being supplanted by alternative care. People are just not getting care. And the Canadian literature about this is very straightforward. Awareness and stigma is important. Pathways to care, unclear. People don't know how to get care. The people who are offering care and the models of care people think aren't acceptable, so they're not getting care. People think that services aren't sensitive and so aren't culturally competent. There are financial barriers to care. Co-payments make a difference. But also, if the care isn't anywhere near where you are, sometimes in Toronto, in Ontario, you might have to take a day off in order to take your son or take your daughter to get care for their mental health problem. People can't do that. And then there are 20% of people, or 34,000 people, who have a language problem. And that language problem doesn't mean they can't speak English or French. The question is, how can you best get care? When you're ill, when you're sick, do you want to speak English or French? Is that going to be the best way that you're going to be able to communicate your complex distress? Or should people have the right to treatment in their own language? It's interesting, in Canada, you have the right to an interpreter if you are charged with an offence. You do not have the right to an interpreter in most jurisdictions if you are ill. In Toronto, we have a particular problem. These red areas are the electoral wards where we have over 40% of people are immigrants. So Toronto is hyper diversity. 18 of our best hospitals are here. Okay? The need is here. So we structure problems with pathways to care. We structure inequities in care by just not putting the care where the people are. But there is quite a lot of research in Canada about what you can do. There's work in Canada that shows that if you do health promotion that targets specific groups, that you can increase the number of people coming into care and decrease the time between when they get ill to when they actually come and see someone. If you work hard with community groups to increase the amount of trust that people have in the system, people come and get care. You can decrease inequities that way. If people are trained in cultural competence, it makes a difference. People turn up, people stay in care longer, outcomes are better. Canadian studies showing that. If services cooperate, so that health or mainstream services don't try and do everything, but link with community services, link with religious groups, and try and offer a diversity of services, more people get help, it decreases the inequities. We have the information out there in what we can do to make things better. Now, I'm not necessarily very good with technology. So in Google Images, I put in ethnocultural man puzzled, and George Bush came up. I put in ethnocultural woman puzzled, and George Bush came up. I thought on a higher order that George Bush just wanted to be on this slide, and so thought, you know, if it means that much to him. So George Bush is on the slide. It's got to be, when we think about what we need to do, we just need to think about what the problems are. So the inequities are happening at three levels: differential need, an inequitable service response, and the context in which that service response occurs. So say, for instance, I want to move my schizophrenia doctors out into the community. They won't go out in the community because the pay structure states that they don't get paid for it. And so that's the sort of context. We've got 4 different groups of people who are involved: clinicians and clinical teams, organizations, we've got the service system itself, and then we've got the society and the legislature. And I think it's just important because sometimes clinicians feel overburdened by some of these statistics and some of the disparities in just remembering who does what. So when we're talking about differential need and the social determinants of health, that is something that is really looked after by the service system and the society and legislature. There's not a huge amount that clinical teams can do by themselves about the social determinants of health. We can all work together in making sure that there's an equitable service response, everybody's responsibility. And when we're talking about the context, we have to be in a position where organised groups start talking to the service system and the society and the legislature about producing a level playing field that allows people to develop and offer equitable services. But it's important that we know whose responsibility what is, because otherwise what happens is clinicians think that this is all too big and this is what they need to do. They need to develop an equitable service response. They need to understand cultural competence. Their organisation needs to work on pathways to care and being in the right place so that people can get access to care and diversity of care. But they can't do everything. It's everybody involved in this. We've taken this up in the Mental Health Commission of Canada, and I've got about 2 minutes or so, and I'll just whiz through this really quickly. Sorry? That's it. That's it. Okay, so thank you very much. And so we went through this in the Mental Health Commission of Canada. We did a huge amount of work trying to go across Canada, working out what this thing should look like, how we should improve services. And the wonderful thing was that there was some very straightforward consensus. Clearly, we needed to work out how to meet the different needs of different groups. It's not just about differential need and differential rates, it's about what we do in services. And that we actually have to take this idea of health equity seriously, because it is all about health equity and our responsibilities to develop an equitable response. And the first thing we want, and then we decided that there was this, what we call virtuous triangle. And a virtuous triangle looks simple, but some of it is difficult. So at the top of the triangle is coordination of policy, knowledge, and accountability. There have to be leaders who are going to push this through. They have to have data. They have to actually collect data so they know who needs what, and also data to monitor whether they make any difference. What they do makes a difference. The data is important. Someone has to be accountable. At the moment in Ontario, no one is accountable for delivering equitable mental health services. And not surprisingly, nothing happens, because no one's accountable and no one can be held accountable. But if you have a plan, if you have the data, if you have the person whose responsibility it is, and if you have the leadership, you then have to go to the communities. You need to go to the communities for loads of different reasons. That's because people are already doing it in the communities. They know whether your data actually is right or wrong. Plus, you don't want to duplicate the work. Plus, there's loads of people out there who actually have the skills to help you move forward and can tell you what strategically will work. And once you've got those two parts of the triangle, once you've got the coordination policy and accountability, once you've got the communities, families, and consumers involved, that's where you then start producing more appropriate and improved services. And it's a virtuous triangle. And it isn't rocket science. It isn't new. It's very straightforward, but it's about doing it. And it's about making sure it gets done. But if you don't have all parts of the triangle, then you have some difficulty moving forward. So I said I would finish on time, and no one believed me, because it's a slow start to try and get us all on the same page and to try and help the conversation as we go further. I'd like to thank you for your attention, turning up in good humour, and laughing at my jokes. Geez, warm welcome. Okay, and thank you very much.